Good evening, everyone. We'll dive straight into this panel. Thank you all for joining us. This panel, as the name suggests, is going to deal with sort of these tough choices we've had to make throughout this year, balancing individual and collective rights in the interest of public good. The pandemic has called for immense personal sacrifice throughout the year, where people have been asked to stay at home, travel less, meet others less. Millions have lost their jobs and millions others have lost their access to healthcare. Some interventions, like using facial masks, have been considered cornerstones of the public health response to the pandemic, and yet have met with violent resistance, including in the United States, claiming that it impinges on personal freedom and choice. In India, on the other hand, cities continue to seal apartments and enforce institutional quarantine, even a year out into the pandemic, where people are asked to leave their homes and go to isolation facilities if they are found to be COVID positive, despite dwindling scientific evidence that this is either necessary or effective. And now in 2021, the world has begun undertaking the world's largest vaccination campaign at a time when there is significant vaccine hesitancy. If large numbers of people do not take the vaccine, we may or may not reach herd immunity, risking that the pandemic will draw on longer than it really should. To help us think through these very difficult questions and to examine historical precedent, we have joining us three stellar public health experts, most of whom here have been my mentors for a very long time. Professor Amar, Jesani, who founded the Forum for Medical Ethics Society and is editor of its journal, Indian Journal of Medical Ethics. Professor Richard Cash, of the Harvard Public Health School, whose vast research career has spanned the globe, but with rich expertise in South Asia, especially in Bangladesh and India. Many of you in the audience are familiar with Dr. Cash. He is definitely a household name in the public health community in South Asia. Professor Jennifer Leaning is a professor at the Public Health School and the Medical School with rich expertise in complex humanitarian emergencies around the world, and one of the founding directors of Physicians for Human Rights. Welcome, Professor Leaning, Professor Cash, Dr. Jesani. The format of this panel will be such that we'll have 3 rounds of questions with the panelists, and we will then open the forum to the audience. So we all have an opportunity to ask the panelists questions. My first question to the panelists is, this doesn't seem to be new. These lockdowns, these restrictions on human mobility and freedom, the public health community has dealt with this in the past. In the recent past, at the end of the 20th century, and for a couple of hundred years before that through various pandemics. Can you shed light on the historical precedents and context within which these debates about restricting personal freedoms in the interest of public health have occurred in the past? Professor Leaning, may I request you to start?
Yes, thank you. Satchit, thank you very much for the invitation to participate in this wonderful discussion. Dr. Jesani, it's a pleasure to meet you. And of course, Richard, it's always a pleasure to share a platform with you. The history of communicable and contagious disease in the world is rich, very long, and filled with tension between populations who have a disease and the authorities that are trying to control the spread of that disease. This is a very long and complicated story. I would just like to point out that there are evolving rules, both legal rules, that is, political movements and states and judges have determined certain kinds of legal parameters for enforcing ways of protecting populations from disease. And then there are long practical histories of how populations have responded to these rules. There is one very famous plague in London. Plague is not COVID-19, but it is basically a contagious disease, and it spreads fundamentally through contact with rats and vermin. And it's at the time of 1665 in London, there were many rats, there were many people. It was very crowded. It was a very poor city for the majority of the populations who lived crowded together. And Daniel Defoe is an observer who has written a phenomenal account of the plague years in London. And what he describes in terms of what the authorities did to lock down the population and separate the healthy population from those who were known to have plague is very similar in terms to what we have witnessed, at least in the United States and in many parts of Europe, with the strategies taken by governments to separate the populations from those known to have COVID-19 and to protect them through lockdown. And as we have witnessed in our own societies, families and populations resist lockdown. They don't like it. It has major social and economic implications for them. And in London, Defoe watched the numbers being tracked by the boards of health in various subsets of London. And he was in one of the last parts of London to get infected in terms of the disease rates. And he watched as the disease began to come closer, now this is plague, to his own wide neighborhoods, how the wealthy left town. They just left. They had money, they had transport, they had ways of keeping all their supplies. They left town. They left London. The middle class who had servants decided that they could, but didn't have a second home. They decided they could stay down in their quarters, which were relatively luxurious compared to the majority poor. They would have food and water. They would stay in their places, and they would endure the lockdown. What they didn't realize is that the lockdown would mean their servants could also not go out and bring in fresh food. And the poor had no options. They just huddled in their ramshackle quarters and tried to endure, thinking it might be a slow, not a very fast process, but not last for months. It lasted for months. And what happened to enforce the lockdown in London is that the boards of health mandated that there be a guard, an armed guard stationed outside each house that was under lockdown to make sure that people didn't leave. And there were problems with this because all of these lockdown houses needed to get reprovisioned. So they'd ask the guard to go to the market and find whatever he could and bring it back for the household. The guard would. And in that period, many in the household would flee out the back windows, et cetera. It's a fabulous story of how populations actually tried to get out from under the rules, which they didn't respect, didn't really understand. The fundamental way in which plague was dealt with throughout Europe, and as far as I know, in most of the other parts of the world, China has had the longest experience, is that anyone who had access to wealth and transport would get away from the infected area. You know, the queens in Russia, the kings and queens in England, they would just pack to their country houses, 50 miles, 300 miles away, and live there until the plague burned out in the towns. In the situation we have now in the world, the countries have tried to impose lockdowns and other forms of confinement of populations. And we still see the wealthy do what they want. The poor people suffer because they can't find livelihoods or food. And what has happened in this period of time has been challenge, political, social challenge on human rights bases to have a lockdown or a control on population movement. And in the last 30 years, there's been the development of UN principles called the Syracuse Principles, which were named so because of the conference took place in Syracuse, Italy, that defined the grounds under which the political authorities had had the legal right to impose restrictions on human populations. And these are very interesting rules because they say it can only be done at extreme levels of danger to the population. The restrictions have to be in accord with scientific understanding of the way in which the disease spreads. These cannot be imposed arbitrarily. In other words, we're going to shut down part of Boston or part of Bombay, and it's because we think there's a lot of disease there. It has to be based on scientific understanding of where the disease is prevalent and where it is spreading. And then the other part of it is that it has to be reviewed very frequently in contact with the population, so that this cannot be a year-long imposition of restrictions. So there's an attempt to balance the public health with the human rights of the individual. And these are the principles that are being advocated for in much of Europe and in the United States. But they're not, in my view, as clearly articulated to the general public as they should be, because they hold in tension what the government can do and what the rights of the people are. And that tension is fragile. It has to be maintained with the general permission of the public and in terms of scientific understanding. And it has to be renewed very often. In the times when it's been imposed in the last 20, 40 years, there's been an interaction between the government, the doctors, the medical societies, the boards of health, and the local government. And so it never holds really strongly for a long time. So this is a way of saying that it's difficult, very difficult, to impose a lockdown, have it be watertight in any manner of the word, and to have the population stay in conformity, in agreement with that lockdown. People will always find a way out. And that's what we see happening with COVID-19. Thank you.
Thank you. Thank you. Thank you very much. Richard, that brings me to you. I sort of want to pick up on the Syracuse principles and the idea that there has to be an identified danger to communities, sound scientific understanding. It cannot be arbitrary, and there must be frequent reviews. Can you comment on sort of what these conversations may have been like at the start of the HIV pandemic? I remember in the early years of medical school, there were conversations that there were countries and governments that wanted to take HIV positive people and quarantine them essentially. You know, if they were identified, they wanted to keep them separately away from towns, cities, or countries. And of course, these ideas didn't go anywhere. And can you help us walk through that process and why it was okay to lock down people for COVID or plague, but not for HIV? What were sort of the ethical considerations around these kinds of conversations?
Well, I think Jennifer has, again, thank you for this invitation, and hello to my colleagues and friends. I think Jennifer has articulated it very well. The problem with lockdowns of any broad attempt is that invariably it affects the most vulnerable people in the population. It's not universally applied. It's applied fundamentally to those who are the most vulnerable, not disease-wise, but most vulnerable politically and economically. This idea of quarantining goes back a long time, but invariably we tend to blame the victim. During the plague years in the 1300s, 1400s, they would burn people at the stake because they were invariably marginalized in society, whatever group that was. Jews, gypsies, you name it, they would go after them. In fact, many people feel, and I'm one of them, that the whole lockdown activity in India was very much designed to protect the middle class. That in fact, it did nothing to help the poor. In fact, it increased their vulnerability. So this is why attempts such as the Syracuse Principles have come to be. Now, does that mean that quarantining or isolating people who are ill has no role at all? Well, it depends on the society. With HIV, interestingly enough, Cuba used that very strategy. Cuba confined individuals who were HIV positive, and they did this in the very, very early days of the epidemic when it was not clear how it was transmitted. And they kept these individuals, not whole societies, but individuals away from others to prevent the spread of the disease as they understood it. They relaxed it later on, and it was a society that could do this because of their form of government. Was it the right thing? Well, the Cubans would say it was right for us at that time. And in fact, Cuba has the lowest prevalence of HIV anywhere in the Americas. Does that justify what they did? We could leave that open for discussion. But generally, in more open societies, these kinds of strategies have extremely limited value. The lockdown strategies, there's no evidence, in my view, that lockdown strategies alone had much impact at all on the COVID epidemic. What was important and what was oftentimes missed was the use of face coverings. I won't even use the word masks. Face coverings were far more important. Limited quarantine, and I don't like the term lockdown because of all of the things it implies. Limited quarantine and isolation had some value. But at this point in the epidemic in India or in the United States or most of Europe, lockdown has a limited, if any, value at all. What does have value is the protection of an individual from infection through the use of face coverings. But the need for the Syracuse Principles and so on come about because, as Jennifer noted, class and social, the social content in which an epidemic occurs invariably affects negatively the poorest and the most vulnerable. And you can just go back to the plague epidemic in Mumbai as yet another example of how it was imposed and it affected the most vulnerable populations. The wealthy get away, the wealthy pay off, the wealthy can confine themselves to their homes. The poor cannot do any of those things. And invariably, they become the ones who are most negatively affected by this. And in addition, I would say they are also the ones who have the least access to any health care should they become infected. So not only are they differentially exposed and punished, they don't even have access to the very health care that would help them should they get ill. So they're triply damaged by these strategies. I'll stop at that point and allow Amar and others to speak.
Thank you, Richard. Amar, over to you. The Indian context of this, where have we struggled with these questions in the past? Leprosy and Baba Amte's work and Anandwan comes to mind, and sort of the stigmatization that is associated with contagious disease. We've seen, that initial horror with COVID in March, April, and May around the world, and I think once it spread so much, everyone knew someone that had COVID and the stigmatization goes down a little bit. Just thoughts on what the challenges locally were.
Well, thanks for this opportunity to be here. And hi, Richard. I think I'm meeting you again, after some time.
Yes.
And Jennifer, I'm meeting you for the first time. But it is quite enlightening to hear both of you about this pandemic and its impact. When you talk about stigmatization, we are talking about people in the society doing something to those who are supposed to be having a different uh, disease or different kind of characteristic. So you are trying to stereotyping certain kind of people, and there what you find is that there is a lot of problems within the civil society, a section of people treating other people in a different manner, and what kind of position the state can take at that time is very, very important. And you find that in the modern times, at least my generation, looking at from 1970s onwards, where the state took a very, very progressive position on issues like leprosy, saying that, well, the stigmatization is wrong. Although most of the strategies they use may not have, helped so much in removing all the stigma, but definitely some of them did succeed. So we have to look at both how people treat each other and the same time in which way the state really provides encouragement for the right kind of behavior by the people. Now, connecting it to the COVID is very important because if the state becomes partial, if state sides start saying that all people who are contracting say leprosy are sinners, they have done something wrong, morally wrong, or all people who contract HIV are immoral people, then you can find that the state and civil society, both of them, come down heavily on the people who are suffering. And there you are not only just blaming the victim, but you are also punishing the victim in a very, very, very concerted manner. I think that is where big pandemic issues should be located. And I found that in India in March, April, May, there were several episodes where this thing seemed to have happened. See, what happens that if a state does not create confidence in the people, does not take them into confidence and make them trust the scientific information, but becomes the spreader of unscientific information. And it looks to the people that state itself has got scared of the pandemic. And so that's what's happened in India, that suddenly in 4 hours time, the Prime Minister of India declared lockdown. At 8 p.m. he comes on the TV, he said from 12 o'clock tonight, there is going to be lockdown the entire, I mean, the people were given just 4 hours to adjust to it and to understand what kind of pandemic that we are facing and all. Till then, there was one army, that everything was going on normal. Very few, danger signals were there, and there was no effort made to scientifically educate the masses. And as a consequence, the first few months, those kind of stigmatization, as you are mentioning, were extremely there. And you find that the stigma and the vulnerable people within the society, they seem to be gelling together. The stigma against disease and the people who are vulnerable or people who are supposed to be less important. You have migrants, you have people who are minorities, people whom you consider to be responsible so much of certain miseries that people are suffering from, and that's where the India really created problem. You had just at the time of lockdown, a congregation of Muslims in Delhi, the Tablighi Jamaat, right? It started a few days before, and the state media as well as a lot of people said that, well, this Tablighi Zaman is a spreader of infection, and said that they are doing COVID jihad, because they were Muslims, because they are minorities. And today, after 1 year after that event, every court in the country where the cases were filed against those Tablighi Jamaat people have dismissed the cases, saying that they all were innocent. They were just meeting like anybody else, and few of them were COVID positive and they needed care rather than stigma. So I think this point is very important, that even Syracuse principles says that state must reciprocate when it tries to restrict the rights of the people, and that reciprocation is to care for them. If you have if there is a scientific need to have lockdown, we can discuss whether lockdown is scientifically needed or not. Professor Kesh can say, well, they are not needed. But suppose it is needed, then what is the state obligation? And that is the moral obligation, ethical obligation. If state does not fulfill that moral obligation while locking down people and acts in a very discriminatory manner, that the middle class and rich are protected, poor are just left to fend for themselves, allowed to get infected and that kind of stuff. They are not provided any means to survive. Poor just didn't have anything to eat. In India, millions of people started walking back to their native places, right? Thousands of kilometers they walk, right? That's where I think is the issue of human rights coming up. That if state does not fulfill its ethical obligation, then human rights gets violated in a very big way. And the last thing that I want to connect it to this lockdown and Syracuse principle is that during this kind of restriction of the individual liberty, Syracuse principle says very clearly that there should be grievance redress. The justice system must function, because when individual liberties for the control of pandemic is used, there are a lot of possibilities of it getting misused by the state agency. It can be misused by the top leadership of the state, or it can be misused by the local level administrator who are actually enforcing it. And so those who feel aggrieved by it, they must have fora available to go and get justice. But what happens oftentimes in the lockdown is that the courts, the justice system gets also locked down, and it does not prioritize cases which are where injustice is being done by the state agency. And remember, restricting people's individual liberty is a dream of most of the authoritarian regime. And if pandemic becomes an handle or a vehicle to do it, they do use it, unless there is a system to push back, and that is the justice system. And you have to keep the justice system alive in as well as possible. Then there will be quick resolution of this kind of issues that turned up in India, in the first few months of the lockdown. So this is a very interesting area that we need to explore. That why things went wrong in India, and it's an area of more research in coming time. Yeah, I will end here.
Thank you, Amar. And these are, as much as we're talking about India, the Indian Science Festival, it isn't that the majority of the countries got this right either. And in India, you still have a population that is not debating whether masks should be worn or not, whether or not they wear it. But you don't have riots in the street with folks not wanting to wear a mask. When the Prime Minister asked India to stay at home, India stayed at home. You had 1/6 of humanity willing to comply, at least initially. And so you had kind of, whether willing or not, you had some kind of synergy between state messaging and population behavior, at least in the early weeks before folks realized that this would drag on for months. In the United States, we have this bizarre and unprecedented moment because of its abysmal leadership, where even the simple act of wearing a mask is debated as an infringement on personal freedom. Professor Cash, Professor Leaning, you'll have spent your entire professional careers here at the public health school. People wear seatbelts, people wear helmets. Why not masks? Can masks not be mandated? What was it like when seatbelts were first mandated? How should a public health practitioner or a scientist who sees that there is something that is in the interest of either individual or collective good to communicate to society, that they should use it. Should it always be voluntary? Should it always be through education and volition? Should individuals always be given the choice? In which case, why do we have rules for seatbelts? Before you answer me, I want to acknowledge that there's just some extremely important, fascinating questions on the Q&A, and we'll make sure that we'll come to those very quickly, very soon. Professor Cash.
Well, I think that you pointed out something very important, the whole issue of communication. I think in the United States, for example, the wearing of facial covering, the message was botched, in my view, both by the public health authorities, and then it was taken up as a political issue. The message should have been very clear from the beginning that this is something that's very important. But there were mixed messages from the CDC. Well, it's not necessary because, well, we want to save these masks for the health workers, but now it is necessary. And so with these mixed messages, people took the one that they wanted to work on. Then it became a highly politicized issue. In my view, had we taken this up right from the get-go, and the message had been clear, I think we would have had far less of a problem than we have now, which is now, of course, widespread. I think that education and clear communication is absolutely critical, but there are times when, in fact, we mandate that individuals, as part of a collective group, have to follow certain rules. You can't drive down the street at 90 miles an hour simply because you feel you have a right to do it. You can't drink and drive. You can't be intoxicated with alcohol and drive. There are a lot of rules out there that we are mandated to follow. You must follow traffic rules. You must follow public intoxication rules and so on. So it's not like this is something totally new. The wearing of seatbelts began as an educational campaign, and then the state said, we're going to mandate this. And if you don't do it, you pay a fine. That is, that there is a price to pay for those who choose not to follow the regulations that we have set. So the idea that you can't mandate things, I think, is absurd, because we do it all the time for all sorts of things. We say you have to wear a helmet when you drive on a motorcycle. That we're going to fluoridate the water, and on and on and on. There's so many different things, but all of these are precluded by an educational campaign to tell people this is why it's important and this is why we're going to do this. Now, there is, as Jennifer pointed out and Amar pointed out, there needs to be an opportunity for people to redress, to go to court, to say, I don't want to do this, and here's the reason why. That's very, very important. And certainly it's very important in our society. But the idea of mandating masks and so on, I see no inconsistency with many public health activities that we have introduced in this country and in many other countries. That would have very much obviated the need for massive lockdowns rather than a collective approach to reducing the spread of this particular respiratory illness. And by the way, we've had this, our information on this and our data on this goes way back. This is not something new. Respiratory diseases have been with us, whether it's the 1918 influenza epidemic, H1N1, on and on and on and on. We've known all of this sort of stuff. This is not, COVID-19 is not some sort of highly unusual respiratory pathogen. We've experienced this many times over. We don't do very well in learning whatever lessons there are to be learned. That's one of the problems. Thank you.
Jennifer, did you want to add to that?
Well, I agree completely with Richard and would like to pick up a couple of points that he made. The messaging on the masks was really chaotic, as he said. You know, these people have to wear them, these don't. Oh, actually, maybe a mask isn't required in the setting, etc. So it was completely confusing unless you were really carefully watching the evidence grow.
And to just give our Indian audience context, in the early weeks in the United States, when there was mask shortage because of the supply chain interruptions, you had senior public health officials, well-respected senior public health officials, go on live television and say, don't wear a mask, it's of no use, save the mask for healthcare providers. And you know, Dr. Cash would argue that what they should have said is leave the surgical mask for the healthcare providers, put a facial covering on your face, but everyone should mask. So by the time the messaging changed, and this is what Jennifer, you're referring to, it sort of became very, very confusing. Sorry to interrupt, I just wanted to provide our audience some context.
Very good point. I mean, the public officials were basically colluding or because of lack of knowledge, contributing to real inconsistencies and misinformation. But the other issue was that there was a controversy that again was within the authorities, public health authorities and science, that should have been dealt with quite quickly, which was, you know, how does this virus spread? Was it large droplets? Is it aerosols? You know, how big a space do you have to leave, et cetera? And notions of ventilation were completely unclear. So the messaging for at least 4 or 5 months in the United States with this virus about how the public should act with relationship to proximity and face covering and ventilation was completely mismanaged. The other point is that this is a society, the United States, that does not like to be told what to do. I mean, no society does, but this is a particularly fractious and contrary society, made more so by the political leadership over the last 4 years, but for years going back. And we're going to see this play out now, the fractious nature of this society, the United States. But it is also the case that if you compare it to the seatbelt program, that was introduced carefully, gradually. Remember, there had to be a big discussion with the car manufacturers to have them have vehicles made with seatbelts. And the car manufacturers actually moved quite quickly to recognize this. And it came into consciousness here in the United States once there began to be very good data, and it was being collected. It had just not been publicized by the National Transportation Authority about how many people were being killed every year on the roads, and their estimates about the numbers that could be saved if there were seatbelts. It turned out the estimates that they first started with were too low. It turned out that once the seatbelts were introduced, once it became law, once people began to obey the cops that stopped them, the policemen, and said, you know, you have to have a seatbelt. I mean, the casualty rate dropped by half. And prior to that, there were upwards of, you know, 60, 70,000 deaths a year at the peak from car crashes. And you compare that to the total casualty rate from the 15 years of the Vietnam War. They were starting to look equivalent. So the horror on the roads and the data that began to be contributing to public accommodation, you know, was an important aspect. But this is many years. I mean, I'm not an expert on seatbelts, but it took many years to do the law, the manufacturers, public consciousness, a sense of, oh my God, how many people are we really losing every year? Medical community came in because they said, this is carnage. All these young people come in with head injuries. There's nothing we can do for them. You know, the emergency medicine community was very active. So the campaign to expect that a society that is rebellious against the government in many ways anyway, which is, you know, you need to know your country, but to expect them to put on a mask because of the enormous mixed messages and the short time frame under which this catastrophe is unfolding is unrealistic. But on the other hand, it is not something that other societies went through. They adopted it, they tried, they did everything possible. So that is why the United States has the highest death rate, the highest case fatality rate, the highest numbers on all parameters of any country in the world, despite being compared to the major colossus, India and China, and much of Europe. It is an astonishing failure of public government.
Thank you, Jennifer. When we come around to you, you've become less audible than you were before. If you could just reposition where you are in relationship to your mic.
Fine, I'll get closer. Thank you.
Thank you. Amar, that brings me to you with the next question, and through that, let's open up the questions to the audience. There are a whole series of questions which I encourage both of you to all three to look at as well. But vaccination is on everyone's mind now, Amar. And what should we think about in terms of vaccination in India? What are going to be the ethical challenges? Should it be mandated? Who should get it first? Who gets it next? Who decides? Who decides? What are the ethical? You are the editor of the Journal of Medical Ethics. What are the ethical questions one has to answer while distributing vaccines in India?
Well, before I come to vaccine, I just wanted to the contribute to the previous round of discussion. This whole issue of limiting individual liberty, mask, and why this thing happened. There were no big controversy about mask in India. I don't remember seeing a single demonstration where people say that, well, you're dictated to wear mask is bad. Yeah, US is very high-tech society. If you say that something needs to be done, then it should be available as a commodity, then it is fine. You go in the streets and anywhere in India, most of the people will not have masks, but they will have a cloth put there, so that what Professor Cash is talking about. I think that's what people were doing, and still they continue doing it. The point, however, on the larger level is that when the state dictates certain stuff, then what are the state's own obligation? I think that is where I still, the state, if says that you should put on mask, or they say that everybody should have vaccine, does state having any kind of obligation to ensure that the vaccine is available free of charge, where people can't afford it, that they will get the mask they are required? I can also respond to this, that if you declare lockout, do you have to, is state having an obligation to see that I don't starve? It's not true that during India's lockout, people believed Prime Minister and did not come out of the house. In Mumbai city, half of the people, that is anywhere around 8 to 10 million people in city itself, do not have housing where they can sit for 24 hours within their room. In one room, there may be 12 people staying, 10 people staying, 5 people staying, right? Most of them were out. And most of them were not only out, but they're also getting clubbed, many of them getting clubbed by the policeman, because the lockdown was enforced like a curfew through the policing agency. If you really communicate well, as Dr. Kesh was saying and Dr. Jennifer was saying, if you really communicate very well and people understand the scientific need to have that, and then they have a means to enforce it, to do it in their personal life, then I'm sure they will follow you. But if your communication is bad and you have really not thought through that an order that I'm giving, is the opposite person will be able to follow it or not? Is the person having a life situation to follow it or not? I think that is very, very important. And if that is not done, lockdown fails. And that's how what happened in India, that after lockdown and people had to start walking, that was a complete violation of whatever Prime Minister was talking about. And they kept denying that people were walking on the road, and millions of people walking, not one. After partition, this kind of migration was seen for the first time in India on the roads. And they kept denying. Even the Supreme Court denied initially, and ultimately they had to accept it, right? That yes, this is happening. Do something about it, right? They took the infections everywhere, because they got infected when they were sitting in cities for first 2-3 weeks. And when they could not survive because they had nothing to eat, they started walking and they took the infection with them. So what happened during the lockdown in India as compared to the lockdown elsewhere, that instead of infection coming down and stopping, as it happens, say, in South Korea and other places, without lockdown and doing a lot of contact tracing and all, we had more infection, right? And actually, it's a very ironic that when we are lifting the lockdown, our infection is going down. That is where you will have to look at epidemiology and how infections actually changes, people's biological thing, that whole immunity that comes and all, the herd immunity you were talking about. The last thing that you are saying about vaccine. Well, vaccine is having a massive debate at the moment. There are 5 trials of vaccine have taken place in India, and they are going on. And emergency approval to 2 vaccines have been given. One is AstraZeneca vaccine produced by Serum Institute of India, and the second one, the Bharat Biotech, the Indian vaccine, which is developed in India, and there have been a massive controversy about, particularly Bharat Biotech, where the third phase of trial is still not completed, but it is being given permission to vaccinate. So that is one area that what happens during the clinical trial, and there are debates, and is it right to, we criticize Russia and China for providing approval after second phase of the trial, but we ourselves are doing it now. In India that has happened. So there are issues. The other issue is that will people get vaccine free of charge, right? So far, to the health workers and people who are in a vulnerable position, like people who are having age above 50 and below 50 with comorbidities, they will be provided free of charge vaccine. But rest of the people, what will happen to them? There is no clarity. And it seems that this vaccine, while being provided through the government system, they will also be made available in the market so that people start using it. So we are worried that if vaccines are really good and if they are useful, then the government should provide universal access to it if they are really interested. The scientific question that Dr. Kesh can ask is that with the infection going down so drastically down, today there are about 18,000 new infections reported in India, 18,000 for 1.3 billion people, and it is going down. New infections are going down. Are we really in urgent need of vaccine? If so, are we in the urgent need of the universal vaccination of every individual in India? I think this scientific question needs to be asked by and answered by some epidemiologists to tell us what should be done. I think that is not being debated on a large scale. Should we be investing so much in the vaccination, or should we be investing a lot in the health system, a public health system, which functions well in case the second wave of infection starts in India? I think these are the issues that may be coming up in coming time for all of us.
Amar, thank you so much for raising that fairly, polemic and controversial.
Absolutely, very controversial.
Yeah, and is immunity going to last? Right? We're still only a year into the pandemic, and if we find that it wanes, then not vaccinating people will come back to bite government, saying you had an opportunity, you didn't. These important questions. There are a lot of just wonderful questions in our Q&A, and we have limited time. So I'm going to request the speakers to feel free to type some of these answers, as well as use the next few minutes for a Q&A. Can I ask the organizers for a little clarification? Do you have another talk right after this, or can we go over a few minutes and try and answer questions? Could one of the organizers?
So you're free to go ahead. We don't have a talk lined up, so we have time.
So we'll extend by a few minutes to accommodate some very important questions. And will you be coordinating the Q&A, or would you like me to pick some questions?
So whatever works better. We've actually dismissed off a few irrelevant questions, so you're free to pick from the box.
from the ones that are left. All right. There are some questions here. I'm going to try and group them together. There are questions about contact tracing here, which we'll come back to a little bit later because that's a related but slightly separate topic, and it'll be fascinating to get the panelists here to contribute to that conversation. There's a question from one of the speakers that says, well, how's a country like India supposed to manage a pandemic without lockdowns? Richard, of the three panelists, you have probably been most vocal about lockdowns not necessarily being the right strategy. So can I request you to take maybe just 2 minutes to paint what an alternative scenario would have looked like, and then either Jennifer or Amar, if you don't entirely agree with that approach, feel free to chime in, or we'll move to the next question. But Richard, you feel very passionately about this, so 2 minutes. Yeah. What could an alternative look like?
Again, I think that a general lockdown was a terrible strategy, and the collateral damage to other health sectors and the population has been incalculable and won't be calculated, certainly by the government. General lockdowns have there's only been one place where it seems to have some value, and that has been in Wuhan. There have been selective lockdowns in Korea and in other places where they've taken a small population and quarantined them. Let's not use the word lockdown. Let's say they were quarantined. Sometimes early on in an epidemic in Kerala, this had some value. But once an epidemic reaches a certain stage, it has no value really at all, nor does contact tracing, in my view. Contact tracing has a very limited value early on in an epidemic, but once it gets generalized, no. Let me put in one other comment. Somebody asked about, can a democratic country succeed in this? Well, New Zealand has. Last time I looked, Korea, which is democratic to a degree, Taiwan, Thailand. There are a lot of countries which have general democratic principles, and they have done an extremely good job in controlling the epidemic because they started early and used good public health principles. Once it gets beyond a certain point, it no longer pays. And India made a huge mistake in doing what they did. It took a long time for them to roll back after they made those initial mistakes. So I don't think it is a valuable strategy. It was not a valuable strategy in India. And as Amar pointed out, it probably contributed to the spread of the virus. Could I put in one comment on the vaccine issue? I don't believe that India should do a national vaccine program. There are so many other issues that will need to take place, and by the time they ramp up to do it, this epidemic will likely have faded into the history books, which is what is happening right now, and is what happened with the 1918 influenza epidemic and the H1N1 epidemic. And so India should protect some vulnerable populations, but it should not embark on a national immunization program. I think it would be a waste of resources, and it won't achieve what they wish to achieve. That's probably enough controversy right there.
Richard, the problem is that the vaccination will take place, and when you say vulnerable people should be protected by the vaccine, and everybody should not get it. But what is going to happen is that not just those who are on the front line, working on COVID issues, but a lot of people who are very privileged in India, they all are going to get vaccine.
Of course,
and that is going to create an impression that those who are not getting is because the government is not ready to invest for them, but is ready to invest for the privileged one. And that's where the whole issue is going to be debated in India. That if doctors can get it free of charge, politicians get it free of charge, the bureaucrats get it free of charge, why can't a policeman get free of charge, armed forces get free of charge? Why can't the poor fellow in the village get the free of charge, the same vaccine? I think that is going to be a major debate in India, and how to handle it in a scientific manner is an issue for us.
And it's a valid question too, because when you look at the seroprevalence studies that have come out in India, you find that the slums already have very high seroprevalence now, right? In the densely packed communities, there's been a lot of asymptomatic COVID, and the high rises and folks with means don't have as much high seroprevalence. There have been calls and attempts to determine whether seropositivity should define your eligibility to a vaccine, and there are many problems with that, and how long you're going to be able to detect the antibodies in the serum, etc. But that notwithstanding, becomes raises very difficult issues about equity. Who gets it, who doesn't get it, and how do you control the communication around it, as all of you are well aware. There are questions here about contact tracing apps and Indian controversies, Varogya Setu app, and how do you ensure that there is no breach of the right to privacy, etc. I think that's beyond the scope of this panel directly, but I would just like to comment on it as been working with teams around this issue. I think you have to show public health utility before there is a breach of even if there's a temporary suspension of freedoms. And if you cannot show public health utility, then it is hard to justify any abrogation of rights. What has happened in the United States, where we have embraced DP3T and the Google Apple platform, that it is so voluntary in an environment which is so untrusting of governments that you just don't get enough people using it. And so there is no public health utility of the digital contact tracing app in the United States. So any risk, however minimal, to individual or collective privacy is just not worth it, because you cannot demonstrate that it'll work. In places like India, there are issues about just not reaching critical mass. If you don't have enough people with the app turned on, it doesn't have public health utility, and then is it worth taking the risks?
Could I just say South Korea is relatively authoritarian when it needs to be. And there is a high tolerance in South Korea for digital scrutiny. So the contact tracing was done in the first phase extremely tightly and well. And it's only been in the second or third phase, however South Korea wants to talk about it, where now you have a resurgence of the disease. And there are more people coming in, they let down the borders, et cetera. And now they have to get a handle on it again. And they're still using digital technology. But for most societies, that would not be tolerated. So it's an interesting issue. I mean, I think it's effective, but a lot depends upon the tolerance of the society for that kind of intrusion.
Thank you. We are just a couple of minutes over time. I wanted to turn this to the organizers, see if there were questions that are unanswered that they would like the panelists to answer, and then we can just do a quick wrap up, 30-second messaging from the panelists.
Yeah, I think we have one question over here that we'd like the panelists to address. It says, just one second. Yeah, what kind of ethical issues do we need to deal with when it comes to an intersection of public health and medical ethics? So in a pandemic, what are the different types of things that we need to keep in mind? And it's addressed to Dr. Jesani.
Well, I think I have to take a full lecture for that. This is a very broad question. If you are going into, because it's not just about public health ethics. A lot of things we are discussing about lockdown, mask, and the scientific basis of restricting people's rights, and the reciprocal obligations of the state. They're all part of the discourse of the public health ethics. That is the discipline that we are talking about. On the other hand, we never discuss that part, which is very important, and that happened in India. Is that how did India's medical system cope with the large number of patients coming to them, particularly the urban health system? India is a highly privatized, health system. India spends only 1.2% of the GDP, that is the public, spending. The rest are all coming from people's pocket. So what happened during the large number of patients going to the hospital and not finding bed there? Why the high mortality took place? Was it because of the lack of the care available to them? When they went to the hospital. I think this is a very, very important area where the massive, class-based, caste-based, gender-based discrimination took place all over. And in coming time, more and more documentation will start coming on that to show it. But that is also a big ethical issue. That the private hospital charging enormous money in order to treat patients, give them bed and put them in the intensive care units, or the VIPs, those who had more resources and power, they were suffering from mild infection, but occupying the beds of the hospital and not vacating it for the common masses. State not doing enough to take over the beds of the private hospitals in order to ensure that everybody gets, on equitarian basis, the admission there. Those are the issues where rationing in the market, the kind of discrimination that takes place within the hospital, all these issues are being documented. If anybody is interested, can go on the Indian Journal of Medical Ethics. We have a National Bioethics Conference website link there. You can go. 8 National Bioethics Conference had 2 webinars on these issues, and the doctors, prominent doctors from private sector and the government who came there, they admitted that things happened were not good. There was a lot of profiteering by the private hospitals, and they did not care for being humanitarian during the pandemic. And the last issue is all this debate that is not only in India but even in US about clinical trials, how well they have been done. Starting from hydroxychloroquine and giving its emergency access to many other antivirals, which all of them which are found to have no effect there. And instead of improving the basic clinical care for the patients, there was a huge attention given to get those get those magic bullets to kill viruses, which never work. I think these are the all ethical issues which we need to take into account, and the spectrum is very, very wide. So, as I said, that it requires a lot of work. We have published several articles which are specific to India on public health ethics, clinical ethics, and the research ethics. You may have a look at them if you are really interested.
Amar, thank you. I would like to be respectful to the organizers and the time, and for folks in India who are logged in this late in the evening. Any concluding comments from Professor Cash or Professor Leaning before we wrap up?
I just want to endorse what Amar has said, that the National Bioethics Conference was a superb forum where a lot of these issues were discussed. And I would fully endorse those of you who are interested to check the Journal of Medical Ethics, a world-class publication. With regard to treatment, I'm reminded of a comment that Dr. Sanjay made at the meeting, where the poor are undertreated and the rich are overtreated. in India. And a lot of that overtreatment is on with drugs that and I want to emphasize it's very questionable value, if at any value at all. But people are still getting into poverty because of this fear that they're not getting the most up-to-date, though useless drug. So again, I want to endorse all that Amar and Jennifer has said on this issue. And thank you again for the invitation to attend the forum.
Thank you, Professor Cash. Dr. Leaning.
It's been a privilege to be part of this discussion, and I thank both Dr. Jesani and Dr. Cash for their wisdom. I would just say that in many parts of the world, and I'm sure it's true in India as well, but I understand the issues of the privatization there. But the U.S. has highly privatized care in many ways also. That the medical community, and by that I mean everyone in a hospital, there has been enormous heroism and bravery in the face of this unpredictable and still quite unknown virus, from the standpoint of whom it affects and how difficult it is to escape its claws, so to speak. And so I think there's going to be worldwide reckoning, and then in each society, separate kinds of reckoning about how the medical establishment, the hospitals, the scientific community mobilized in ways that were either delayed or urgent and appropriate the more you could learn. And then I think in many parts of the world, and this includes the United States, and I know it's India as well, there's going to have to be a very serious evaluation of how public health works in the country. Public health was allowed to essentially erode in terms of consciousness and infrastructure in the United States over the course of the 20th century and now still. And to me, there needs to be a revitalization of attention to public health and the ethics and the responsibilities of practitioners towards the poor, the disadvantaged. And to me, that is a worldwide conversation. And anyway, I'm privileged to be part of this discussion with all of you and also with our colleagues in the audience in India. Thank you.
That's a wonderful.
Just, very brief. I just want to reiterate what Jennifer said. I think in India also the health workers, doctors, down to all of them, they did a very, very committed work in the hospital. But at the same time, there have been a lot of conflicts between the hospitals and the health workers, because the government hospital as well as private hospitals did not reciprocate by providing the kind of protection that they needed, and or provide them the financial support. Many times doctors and nurses went on strike simply because they were not paid for 3 months and 6 months. It happened in some prominent hospitals. Or they were not being provided protective equipment, even when they were otherwise available in the market. So I think this contradictions needs to be sorted out. That very committed work by those people, many of them died in the duty. And on the other hand, the system not appreciating it and really providing protection. A lot of violence against them, or the doctors getting stigmatized in the community. The doctors were not able to go to that, moving in the community was so difficult for them, saying that these are the infection spreaders. There was a lot of stigma against medical staff within the society, and this protection that they needed about it. I think this is a very important issue, and hopefully they will be sorted out in coming time. And the public health system, as you said, needs to be strengthened as a learning from the current understanding.
Amar, you just got muted.
Yeah, that's it. I think that's yeah.
Thank you kindly, the organizers, the panelists, for this very, very thoughtful and provocative discussion. There are very few countries in the world that got this right, and this was not the first pandemic that we have faced. The lessons and the mistakes keep repeating themselves, sometimes 100 years apart. But we live in a more connected world. Information flows more easily, and hopefully the lessons that we have learned from this pandemic will be better etched, both in our memories, but in the processes that we institutionalize to face the next one, because there will be another pandemic, and the next one is likely to be sooner than later. Thank you to the organizers of the India Science Festival, and sorry about running over time. Thank you, everyone.
Thanks a lot,
Thank
and
you.
good night.
Thank you very much.
Thank you so much, Professor Balsari. Thank you to all the panelists, Dr. Leaning, Dr. Jesani, Professor Cash. It was an absolute pleasure having you all on board. I think you brought in some much needed perspective to the Indian audiences, and it was an absolute pleasure having you on board. Professor Balsari, as always, thank you so much for being associated with ISF, helping us curate and moderate this panel. And we're looking forward to doing more events together. Thank you so much.
Thank
Always
you.
a pleasure. Good luck. Thank you.